Welcome to the CIMT and vascular disease podcast. What we're going to do and what my intention is for those of you that have had a recent um, CIMT performed or had one in the last year. This is just more information. Why is it important? Why would we get a CIMT test? Why does that add value to your risk score? What does that look at? Looking inside the vessel, seeing the invisible, right? The only thing we see in our day to day is our lab work, and we look at risk factors. And, there are really over 300 risk factors. Some say 400. But one of the things we pay attention to here at Redesign MD is the top 20 risk factors. And most people in general modern cardiology look at just 5 risk factors. So and one of the misnomers I think that I just want to get past is that we are very cholesterol centric, and we need to get beyond cholesterol. Of the big 5, it's one of the weakest, quite frankly. So let's dig in. Let's talk about the key concepts that I'd like you to be focusing on so you can have some real action steps to reverse disease and have an assessment of where you're at today and how do we get you from A to B, either reversing or stabilizing some of the plaque that we've uncovered, or the thickness of your artery, which is really your vascular age. So we'll go into that and we'll see here what that looks like. So the illusion here is this. And the illusion is that, doctor, my cholesterol's normal, my EKG looks fine, and we tell our patients we'll see you next year. Unfortunately, that's doing patients a disservice, as that's the end all be all. And so the reality is up to 68% of heart attacks and strokes occur in people with normal cholesterol. In fact, there's an 80% overlap of cholesterol between those that have heart attacks and those that do not. So the first clinical sign ever of cardiac disease is, how would you guess? Sudden death. I clench my chest, I fall to the ground. That's when I first discover I have some vascular disease. That's the number one risk factor, guys. It's not chest pain or shortness of breath or dizziness or palpitations. It's actually sudden death. We don't even know it because we haven't looked at the anatomy yet to see how much disease is present. And that's what the CIMT does, is it looks at your anatomy so we can take a deep dive into how do we stabilize that plaque, how do we reverse it, and move on from there. So the big thing with vascular disease is there's this thing called the clogged pipe myth. And we look at it as a luminal disease. What's in the vessel? Do I have plaque in my artery, or where is the plaque at? And what I'll tell you is, it's not whether you have occlusive disease. What we want to know early on is go way upstream and say, do you have disease at all there before it's in the pipe, before it's in the lumen of the vessel? When it's in the pipe, we're already far downstream. We're already far down the road where we could have intervened much earlier. And I think that's why people they don't realize it until they're symptomatic. They don't realize they have heart disease until I'm short of breath, or I have palpitations, or I have chest discomfort, or some other what we call anginal equivalent symptoms. So let's not focus on the lumen. Let's shift to the right here and focus on the arterial reality that as the disease progresses, there's thickness of that arterial wall. There's thickness and more plaque, more immune cells. There's more smooth muscle migration. There's all sorts of things that increase the thickness of that vessel, and it's related to inflammation. It's related to oxidative stress, which are really the two overarching concepts that we want to focus on with cardiac disease. So remember, we're not looking for clogged pipes unless we're already far down the road. And yes, we might look there if someone's having significant symptoms. However, we're really kind of late in the game if that's what we're looking for. We need to look to the right, and that's what the CIMT does, is it looks for disease in the vessel wall. And so, remember, guessing what might happen with primary prevention isn't as good as actually looking at the anatomy and saying, where is the disease? Is there disease present? Yes, let's look at biomarkers, but not just the top 5. They're very important, but let's also look at other factors that will measure your inflammation, that will measure your oxidation, that will measure the endothelial function. that will measure whether your LDL is actually oxidized or not. There's other inflammatory markers that we can look at that look to see if your immune cells are overactivated to try to rescue that plaque from the artery wall. We could look at that. And so there's a difference between functional anatomy care and conventional care. And so what is a CIMT? A carotid intima media thickness ultrasound that looks and gives us some detail of the anatomy. It has a digital caliper that will actually measure how thick that artery wall is. And so the carotid arteries are in the neck. We have a right and our left side. And we look at both of those because it does matter. And a lot of people have a difference between their right and left. So we want to look at which one's worse because that's where the disease would be worse. So we will look at this and remember vascular disease correlates and we extrapolate that vascular disease in the neck to the rest of the system. It's all one vascular tree. So if you have disease here, you're going to have it everywhere. You're going to have it in your extremities, in your penis, in your brain, and your heart, everywhere else. So that's why it's important. The nice thing about CIMT and carotid intimal media thickness testing is there's no radiation. Radiation is oxidative. It's stress on the body. It causes damage. So if we can minimize that and we can identify your anatomy with a test like this, that's why we bring it into the office. That's why we bring cardio risk laboratories into our office to look at these tests. And so let's get into it. Let's get into your report. Let's talk about some of the key factors here and look at why your arterial age, why early event risk, what is the plaque burden, what is your max regions, how do we measure plaque? So I'm going to explain that right now. And these are important markers. This Cardio Risk Laboratories does a fantastic job at really decoding your anatomy. And so one of the things that we do is with arterial ages, we look how thick your arterial wall is, the intima media thickness, how thick that is, and then we plot it against your aged cohorts. We'll show you that. We look at your early event risk. In other words, what's the peak highest measurement in that arterial wall that looks problematic? That's your early event risk score. And then we look at your average carotid mean IMT. They go by 1 centimeter and do 600 cuts, and they take the mean average of that. So that is how precise they are. Some of these tests that look at your carotid testings only do a few measurements. Cardio Risk Laboratories does 600 measurements. And in fact, they even have variability coefficients where they measure the user to user variability is the smallest among any other company I'm aware of that does these CIMT tests. So that's why we bring them into the office. That's why we don't just send you up the street to any other testing company. And so, and we'll get into uncoding some of this. So your true biologic arterial age. Here you see the arterial age 64 for a person chronologically at 62. Why are they 64? Because of based on their IMT, their average of those 600 cuts that I talked about in the common carotid artery in the neck comes out to be 0.79 millimeters. So that correlates with someone who's 64 years of age. And if you look down at the bottom of your test, you'll see that that's plotted out down there. The higher the thickness, the more inflamed, the thicker the artery is. So if your arterial age is higher than your chronological age, your activities are actively inflamed. So what strategies do we need to employ to lower your inflammation? So calculating your plaque burden. One of the things, if you look back at that score, is when you look at the plaque scores at the bottom of the page, we don't count them unless they're 1.3 and above. In fact, some of the scores you might see at 1 or 1.2, well, we don't count those. Even though they're measurements, we don't think that they're substantial enough or meaningful enough to count them as plaque. So what we'll do is we will cross those out and we just take measurements and we add up the measurements that are greater than 1.3, which comes to a total plaque burden of 4.5. So the bottom line is, if you have a plaque burden score, you have established disease. We must move immediately into plaque stabilization or reversal or regression of the plaque. Both are possible and both happen and occur all the time. This is the goal of cardiologists. of vascular specialists, of preventive vascular specialists like myself or my partner here in the office, Dr. Moss. So this is the early event risk. Like I said, it's looking at one point in all of the measurements that's the highest point. And if that point is greater than the alert value of 2.5, yours is 2.8 here, we're going to say there's an increased risk of early events. Early events, what does that mean? Acute coronary syndromes, which includes heart attacks or strokes, quite frankly. So another beautiful thing that a CIMT does, a carotid intimal medial thickness test does, is it looks at the quality of the plaque, the anatomy of the plaque. When that ultrasound, those waves hit the plaque, does it echo back? Is it highly mineralized and calcified plaque? If so, that's the safest of the plaque. That's a very stable plaque that's not going to easily break off and lodge downstream and cause a stroke or a heart attack. Heterogeneous plaque is a combination, right, of soft and mineralized plaque. It's much more stable than soft plaque. So we worry less about heterogeneous plaque than soft plaque, but quite frankly, it's on the spectrum. It's not quite as stable as the echogenic plaque. So, and then we have the mineralized, or excuse me, the non-mineralized plaque, the very vulnerable plaques, the soft plaques that are made up of just fatty streaks and part immune cells. And those, a high pressure system, a spike in blood pressure could break that off and throw that downstream and cause a major problem, such as a stroke or a heart attack. So in terms of the pillars of arterial disease, it's what I said before, those two overarching concepts, oxidation and inflammation. And so what I'd say is, when we look at this, when you have oxidation, the oxidized LDL gets damaged by several chemicals. We can list all sorts of oxidative stressors in the body, most of which are things we consume every day with food. Some of the chemicals we put on our skin, the environmental pollutants, some of the medications we take, some of the supplements we might take. Inflammation is then turned on, and the immune system says, well, those aren't LDL particles that we recognize. We're going to go take care of those and engulf those so we can remove those from the vascular tree. Well, what happens is they get stuck because the immune cells that swallow the oxidized LDL that is encircled by these inflammatory mediators, they get stuck and they can't leave the arterial wall because now it's a dysfunctional atheroma. And atheroma equates to atherosclerotic disease. So this is a major problem, guys. Oxidation, inflammation. Remember, food is probably our biggest trigger, the biggest thing we're most in control of as well. So some things we might recommend to you to lower inflammation are supplements, better food choices, sleeping better, hydration status. All of these things can lower these factors. Lowering the amount of LDL can play a role. Lowering the blood pressure, huge. Smoking is a significant oxidative stress factor. And thankfully, there's less of that now than there used to be. But there's excessive alcohol consumption and other things that can drive these factors. So there's a certification out there called the Bale-Donine method, and this is a certification that I did at one point. And the Bale-Donine method, they do a great job. And one of the things they do is they really do a great job in uncovering a lot of other things that can contribute to that oxidative stress and inflammatory burden, one of which is an oral systemic link. This is why in your annual exams, we ask, are you up to date with your dental appointments, with your personal hygiene practice? Do you have uncovered illness and infection in your mouth? These pathogens, they find actually have embedded in 68% of the plaques in the coronary arteries on some of these studies. Insulin resistance is a major piece that causes damage to the endothelial layer, that innermost layer of the blood vessel, and rapidly drives oxidation. Obstructive sleep apnea drives inflammation and oxidative stress. Chronic immune activation. We see these immune cells much more activated when we don't sleep well. Heavy metals, toxins, mercury, lead, this stuff is in our food. It's in our environment. The plastics that we consume, right? The microplastics data, looked at the carotid arteries and looked at significant 4.5 increased hazard ratios to your vascular disease status if they found microplastics in your carotid arteries. Yes, decrease your amount of plastics. Try not to drink out of water bottles, plastic water bottles, or heat plastics, certain Tupperware type items in your microwave that is then extracting those plastics into your food, and you're eating them and they end up in your vascular system. So lots of other things here to consider. We're talking about some key topics here today. So one of the things we've mentioned here already is your endothelial shield, which is the most inner lining of the blood vessel, the thin single cell layer that's very responsive to nitric oxide. Nitric oxide does what? It dilates the vessel. So when it dilates the vessel, blood flows better. There's less restriction. There's less damage to the arterial wall. When there's nitric oxide present, the hemodynamics of the vessel works better. When vascular disease progresses, these vessels get stiffer. They get more calcified, right? When we look at coronary calcium scans and we see a large amount of calcified tissue there, I do worry about the hemodynamics of the blood vessels. So I will recommend nitric oxide to those folks. Diet, exercise, age, environmental toxins like we talked about, which is why even certain blood pressure medications can help the hemodynamics of your blood vessel. So these things are important, guys. These are key concepts that we should address if your CIMT is out of range. The oxidized LDL particle. Remember, look at it. It looks diseased. It looks hurt. It looks inflamed. That's why our immune cells come in and swallow that guy up. It's one of the most critical markers, which is why we measure oxidized LDL in your panels. We should look at lipoprotein(a), which is an independent genetic driver of disease, significantly so. Homocysteine and CRP are two other markers that can measure oxidative stress and inflammation and that contribute to this wall thickening or your arterial age increasing. Significant markers that we look at when we look at your vascular system. So let's look at your environment, your lifestyle and your environment, your genes and your environment. So yes, genetics account for 20 to 30% of your vascular disease. Some people have much more severe disease, and we can measure some of those vascular genetics, like 9p21 and several others, ApoE4. Those are things that increase your vascular disease risk. But we can mitigate that. The Amish paradox is they have the FTO obesity gene, but many of them are not obese because they over trump their genetics with the right lifestyle. So they bathe those genes in a lifestyle that suppresses the gene expression. So just because you have the gene doesn't mean it has to be expressed. That's the difference. And so when we bathe the gene in the right cocktail, we can suppress the ability for it to express itself and therefore lower our risk, even with bad genes. I hear this all the time. Well, we've got bad genes for diabetes. I guess I'm going to get it anyway. No, you don't have to. We can bathe those genes in the right cocktail and suppress the expression of that disease. And so that's why it's important. Some key pieces here on nutrition, the nutritional blueprint for regression. Plant-based dominance. Where does low inflammatory and low oxidative foods come? From plants, guys. There's no other way around it. The data is huge. It's enormous. It's impossible to even debate at this point. So I know there's some silly concepts out there. I'm not even going to go into debunking all those. We can talk about those at the end here and see if those are some concerns you have. But plants are king when you're trying to scrub your vascular system and stabilize plaque, reverse plaque. All of those things are great. So pomegranate juice, some studies that show reduction of oxidized LDL. It changes the size of the carotid lesions. There was a study with green tea extracts. 3 or more cups daily has been shown to significantly lower carotid intermedial thickness. So just some things here. There's many more studies like we talked about. Testosterone, believe it or not, lowers intermedial thickness. I'm going to raise my desk here and just stand to talk to you. I do better when I'm moving around a little bit. and healthier for me anyway. So yeah, green tea extracts, a lot of other things. So high dose fish oil shows that it reduces intramedial thickness. High dose fish oil, which is why we can check your omega-3 checks in our annual lab reports. We check B vitamins at times, so we know if there's homocysteine is high. One of the ways to lower homocysteine is with methylated B vitamins that can again lower and reduce your intramedial thickness progression. It showed that if we lowered homocysteine levels 1 year later, we showed lower reductions in thickness of that vessel, which means what again, guys? Lowering inflammation. One of the master antioxidants, a lot of people know that as vitamin C or selenium or several others, but glutathione is probably the master antioxidant in the body, very powerful, crosses the blood-brain barrier, so it gets at oxidative stress everywhere, including the brain. And then again, anti-inflammatories, resveratrol, curcumin, fish oil, like we already said, vitamin D shows that it actually stabilizes soft plaque in some small studies. So again, these things are healthy for us. Adding those and upgrading your nutrition status with targeted supplementation is a fantastic thing to do. So again, we can get specific with that if you're a patient of Dr. Moss's or a patient of some other physician or provider. Important to have those conversations. So the daily commitment of exercise, what we want people to do is commit 4% of their day to exercise. Up front here, what I'm asking people to do, just commit 1%, which is 15 minutes of deliberate exercise a day. So by implementing this 4% of your day to being deliberate with your nutrition, with your exercise, with your supplemental nutrition, whether it's pharmaceutical medication, and targeting what we call the targets for overall risk reduction of disease. But when we look at your anatomy, we can actually look at the disease, and every year, if we want to, or every other year, every 3 years, and repeat those CIMTs, because cardio risk laboratories is a repeatable test, because we know their variability coefficient in test retest reliability, we can see a 4 to 8% incremental change every year. And so if you're working really hard, sometimes we want to get those studies to see your handiwork, quite frankly. Watch that CIMT wall thickness go down. And if we do that, if we have a spreadsheet here in the office, if you check all of those boxes, the likelihood is you will be at least slowing down the process, but the hope is to stabilize and reverse the process. And so, you're as only old as your arteries. And so I believe Hippocrates once said that. I'm forgetting the name of the famous physician, philosopher. But, we have to acknowledge the data. If your CIMT shows plaque, there's disease present. So we just have to attack it. We have to get the spreadsheet. Let's work together, formulate a plan. Let's look at that 4% of your day to really target in on the key pieces to stabilize or reverse your plaque. And let me just tell you, since the last time I did this video, just Saturday, I performed CPR on a patient that had a heart attack. And that's not when we want to target these things. So remember, we need to track the reversal of your disease. We need to track the process so we can move forward with this. We need to change the environment that bathes your genes in the wrong cocktail. So we need to look at the root causes, the toxins, the heavy metals, the environmental pollutants, the plasticizers, the pesticides, the herbicides, your diet, and reassess your diet in terms of your diet quality for oxidative and inflammatory mediators. There's this concept called metabolic endotoxemia that occurs after you eat and lasts for 5 hours, which can constrict your blood vessels down for 5 hours. Well, what happens after 5 hours? It's time to eat again. And so are you feeding your disease or are you feeding your wellness? And that decision note is every time we choose something to put in our mouths. So that's the low-hanging fruit, guys. Exercise and diet therapy. And we need to track it with a test like the CIMT to see if we're making headway. And so one of the things here I'd say is that we like to look at with when we're looking at disease the disease status is we need to look at the genetics. But remember, the genetics load the gun. Your behaviors, your environment, your diet, your exercise, or lack thereof, they're the ones that pull the trigger on the genetics. The genetic expression is driven by your behaviors, your health behaviors, your wellness plan. If your wellness plan is not not smothered in the right cocktail, is not smothered in the right lifestyle medicine cocktail, if the sleep is poor, if we binge drink, if we're doing a lot of other things that are going to pollute the vessels, we should not be surprised the vascular disease is progressing and worsening, even if we're taking the drug that our doctor gave us to lower our cholesterol. Because as I just mentioned, there's multiple other things here that drive disease. And so think about the three pillars: oxidation, inflammation, immune dysregulation. We'll break it down and look at your disease status with you at the end of the webinar, or we'll send this video to you if you've had this done, and we can talk about this further at your visits, whether it's Dr. Moss or myself or another provider. We can dig in a little deeper with this. Thank you for tuning in. Thank you for watching, and look forward to talking to you more about vascular health.